We don't like the idea of a third wheel in the relationship. The idea that there's somebody else coming in to tell us how to do our jobs. We do like the idea of having tools and assistants, though. My pleasure. Thank you very much. Hi, everybody. Can you all hear me? Yes. Very good. Okay. So this is me. I'm a physician trained at McGill University in Canada. I'm specializing in psychiatry. I am the CEO of Aifred Health, which is a mental health AI company that I'll tell you about at some point in the presentation. So disclosure, everything I say is biased because I'm somewhat corporate. I do research in neuroscience, computational psychiatry, and medical ethics and advocacy. Was previously very active in health policy. And basically what you'll be hearing about from this talk are combinations of our market research, some of our research, and some of the thinking and experience that we've had. This is a very active and growing field, so things can change all the time. The point of the talk today is to really tell you a little bit about the challenges and complexities of developing technological applications, especially AI-focused applications, in the medical context. And I really mean the medical context, not the general health and wellness context, the medical context. And I'll explain what that means and why it's important. We'll also be talking about the ethics around that and an ethics framework that we've developed that I'll take you through. There's some exercises at the end. And I think we have enough time that we could probably do questions in the middle if anybody has. Okay? Shall we go? Okay, good. So most of the stuff on the screen is for me to remember. I will say everything that's relevant, so you don't have to try and read the screen. I hate looking at presenter notes, so I just often make my slides terrible. I know it's bad practice, but whatever. So yes, this is an outline that doesn't matter. So why is AI in medicine important? We have seen an explosion in the number of tools, in this case medications, available to us. So this is just a graph of how many medications have been approved by the FDA. Does it not? It just doesn't show on the screen. Okay. It's interesting. Okay, whatever. This is a graph of medications that have been approved by the FDA over time. As you can see, it's been quite a bit more than we had back in the 30s when the FDA started. The only thing that was approved before this was aspirin, apparently. So that is interesting because it's put us in a position where the practice of medicine has changed substantially. A doctor today needs to know a lot more about a lot more complicated things than a doctor 20 years ago, 10 years ago, 30 years ago. And we're being taught by people who were educated 20 years ago, 30 years ago, 10 years ago. And that's interesting, and it leads to this situation where the grumpy old doctor says, you guys are such whiners back in my day, and then we say back in your day you had like 3 drugs and you didn't have to know about antibiotic resistant drugs, and you didn't have to know about the 20 different antidepressants, and you didn't, and you didn't, and you didn't, and all the drug combinations. And basically, we have reached a saturation point. Shit is too complicated now. And that's a problem because it means that on our own, we are not able to integrate all the information we have to integrate to make the best treatment plans for our patients. This helps a bit if we work in teams with pharmacists, for example, and with other professionals. That's expensive. It's actually cost effective, but it's still expensive to implement, and it's not done everywhere. And even when you do have interdisciplinary teams that work together well, it can be a challenge to ensure that you have the sort of processing power to take into account all the information. To make matters even worse, even when you have all the professionals you need, it is not always obvious how to take information about a patient, how to take that patient's needs and wants and expectations, put that together into an adequate care plan, an adequate intervention that will help them. It's not something that is easy to do. I'll give you the example of mental health where it's really not easy to do. And it means that we need help from persons like yourselves who can develop technological applications that can work with us to make our ability to help patients better through the use of smart technologies, whether it be sensors or AI, etc., that helps us integrate information and make better decisions and predictions. There are caveats to that we're going to be talking about today, and that's going to be the interesting bit, because it's not as easy as you may think, and in fact, it's quite difficult. One thing to understand about us is that almost every pain point that we might have comes back to time. Time is the currency that we work with as physicians, and we don't have nearly enough of it. There are more sick patients than there ever have been before, not because the population is sicker, the population is actually healthier than it ever has been before, but the number of complex patients is increasing because people are living longer, they're getting older, they're actually coming to seek care for things that before they would just die of or not seek care for because of social norms. And so the number of people that we actually have to serve in the healthcare system and the complexity of those cases is increasing even as overall the population is living longer. So we really have to consider time to be our main pain point. A clinician does not have the luxury, unfortunately, to sit for 2 hours with each patient. We wish we could because it's fun, but we don't have that luxury. So how can we develop technologies that help us make better use of our time, that help us put that human element back into medicine, that take away some of the busy work that we have to do, and lets us spend more of the time that we do have building a relationship with the patient. So why develop for clinicians? This is a question for you. You might be asking yourself, I can develop the cool new blockbuster unicorn, app that's everybody's gonna use it for 2 years and then forget about it. But at least for those 2 years, everyone's gonna use it and it's gonna be great. Why should we develop something for the clinical domain? Well, this we said already, and 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 this we said already. Now, this is the one for you. Yeah, sorry. So who has any ideas as to why you should develop for us and not for the mass market? What are some benefits that come with developing for the clinical environment? Any ideas? I will pick on people. We have a...
You won't have to go to doctor anymore.
So I'm saying you develop for the clinical environment, which means for doctors.
Yeah, but if there's something that can already treat you within your home, you don't have to go. Like online shopping.
Okay, so what you're saying is reducing the burden on the healthcare system. Yes. Okay, that's one. Any other ideas?
It might sound cheesy, but it has some kind of bigger social impact for the community compared to like developing a new game app.
Sure. Okay. Can you be a bit more specific? There's a really good point you're almost making. I'm going to challenge you to try and be a bit more specific.
Well, let's say you develop AI or something like that to cure a specific disease or to reduce the rehabilitation time after specific surgeries.
So yes, and so I think what sort of is implicit in your statement is there is need in the clinical environment. And there are specific things you could probably make a difference in, that if you're focusing on the general environment, the mass market environment, you're probably not going to be reaching the people who need that support the most. You'll be reaching, sort of people who want to get a bit better at remembering stuff, or who want to get a bit better at their job or whatever. But you won't be reaching sort of the people who are sick who really need that support. Now, there is an argument to be made about large-scale interventions from a public health perspective that can be mass market and help a bunch of people a little bit, which keeps more people to be less sick. I can't think of any actual successful example of an application that was able to have that kind of impact. These are the kinds of things like vaccination or education where you make an intervention for everybody in the population and it helps everybody, even if they're not actually sick. But I can't think of an example of an app that's actually been able to do that yet, because it's voluntary. Everybody sort of decides whether they want to use it, so you have a selection bias into who's using the application. In the clinical environment, you're basically everybody who's there is sick and needs support, and you're able to intervene in a population who most acutely needs the help. So another reason, you don't really have a choice. So if you're really interested in the medical domain, if you're interested in the domain of people with diseases, so not general health and wellness, which is very important, but again, I haven't seen an app make a large-scale difference in people's lives yet. It may happen, but it hasn't happened yet. But if you really want to get into the medical domain and you want to access the funding and the hospitals and all the stuff that comes with that, you need to think about developing for clinicians. Why? Because you cannot bypass us. doctors, nurses, psychotherapists, physical and occupational therapists, all the people who work in the healthcare system are the people that you have to get on board with your applications. You're not going to replace us. It's not going to happen for years. For one simple reason, which is we are bloody good at legislating. We will sue the pants off of anybody who tries to replace clinicians. It has happened before and it will happen again. Some of you may not know this. The reason Ronald Reagan became president of the United States was because doctors didn't like the idea of public health care and basically got together and funded his campaign. It's a longer story than that. But doctors are very good at doing very stupid things to keep their, I did not like Ronald Reagan, doing very stupid things to keep their position, okay? And the same goes for other professionals as well. We're unionized, we're organized. You're not going to replace us. You will be able to augment our abilities. And I think that there's a great argument to be made for augmenting the abilities of clinicians. And you will be able to replace specific functions. So a very good example is using artificial intelligence to scan skin lesions to determine whether or not it needs referral to a dermatologist because it may or may not be cancerous. That's a great idea because dermatologists are actually very expensive and hard to access in many areas. So that's a fantastic example of a specific function that can be replaced. It doesn't replace dermatologists because it can't do surgery. It can't tell you about things that aren't cancer or not cancer. It can't do a bunch of different things. But it can tell you whether this particular lesion is cancer or not cancer. So that's one specific function that augments the ability of clinicians to provide health care. And that's really helpful. But there will be no doctor replacer for a very long time for the reasons I said, but also for ethical reasons, and also for reasons of practicality. Because believe me, I'm in the field, and I'm also in the data science space, and I know what AIs today can do, and they cannot do what we do. Not yet. They can do a small part of what we do for very simple and routine cases, and they can take some burden off of us, but there is plenty that is beyond the capacity of current AI systems in the way that they process complexity, in the way they process longitudinal information. It simply cannot be done yet. What? No, no worries. It may happen. I think by the time it happens, though, the AI is going to be so smart that it's basically just a human doctor, but in silicon form anyway. And then we're going to have Skynet. We're not there yet. Another thing is that legally, we're the ones who give diagnoses and and prescribe treatments. So if any of your applications deal with the act of suggesting or recommending treatments, there is no way that you're going to do that direct to patient because somebody has to sign the prescription. You cannot get around that. And for legal reasons, you're not going to get around that because somebody has to be responsible. And ultimately, you don't want it to be your company because mistakes will happen. People will die because they do. And you will be responsible if there's no doctor there. So we actually serve as a buffer for you legally because we're the ones making the decisions to sign prescriptions. So you don't actually want to replace us because if you do, you'll be out of business within the first few years because somebody will sue you. And it'll be over. I talked about this. Oh yes, Babylon. So I'm sure you guys have all heard about the new Babylon that beat the medical exam thing, right? The Babylon. Yeah, okay. If I trusted my colleagues based on how well they did on their medical exam out of medicine, it will be a very different set of colleagues of who I actually trust. It's not at all the same thing. Firstly, it's multiple choice. Okay, you have answers, you have questions, and like any question, it's designed in a way that if you know enough knowledge, you're going to be able to figure out which comes next. It does not at all test your actual ability to see a patient, ask them relevant questions where they don't answer your first questions correctly, find out the right information, make the right differential diagnosis, and then have the treatment. It might work for very basic, simple things like the flu, which don't really matter, right? But when we're talking about more complex diagnoses, it is not yet proven that this can do it with real patients. A medical exam is not enough for me. The reason we accept medical exams for people is because they are part of an evaluation process, which includes us actually watching people see patients in the hospital, right? So this is nice. It's very impressive. It's a great advancement. It doesn't mean it can actually treat patients on its own yet. Because again, you know, the average I think is like 71. So most of your doctors are like average on a test that you've seen. And I don't think it actually accurately reflects the level of their expertise. This all feeds into an idea that user-facing applications are going to have a limited staying power. There is going to be a limit to any application that is totally and only user-facing in the medical domain. You can definitely help patients keep track of their symptoms and manage their illness and all these things. If you don't have a connection to the clinical world, if you don't have a connection to their clinician, to their physician, to their nurse, etc., you're going to run into essentially a bunch of features that the patient would really love to have that they simply can't have. For example, there are lots of companies who offer genetic testing. And you send in a spit sample and you mail it away. They send you back in a week another sample, a report that says, here are all the things that you're going to die of, and here are all the drugs that aren't going to work for you. And then you're supposed to go to your doctor with this piece of information and say, doctor, so for my depression, here are the drugs that should and should not work for me. There are lots of issues with that. First issue with it is that those pieces of genetic information have varying levels of utility. They're not actually all that useful, which is why we don't do them in clinical practice. If they were very useful, we would do them in clinical practice. Secondly, the doctor is liable legally for decisions that they make. So if they make a decision based off this piece of paper and the decision doesn't make sense to them, they're responsible for that decision if something goes wrong, if another doctor wouldn't have used that information in the same way. Finally, there is a certain amount of, I'll be honest with you, hubris. Doctors are proud, and we don't like the idea of a third wheel in the relationship. The idea that there's somebody else coming in to tell us how to do our jobs. We do like the idea of having tools and assistants, though. We love having assistants. That's why we like medical students, because they do things for us. Well, not anymore, because there are ethical rules about that now. But in the old days, which before I was a medical student, thank God. Anyways, point is that we often will work with assistants. So there's plenty of apps online that we use, calculators online that we use to decide when to do a scan, to decide when to do a cast, to decide what blood test to order, et cetera, et cetera, et cetera. We're very used to using this information. But the key is that we see it as an augmentation of our skills. And that is when you get the integration that lets you bring the patient's world and the clinician's world together, and that's when you're going to get the most benefit and value for the patient. That's also when you open up the opportunity for the payer to not be the patient, which will always limit you, always, because people don't like paying for this shit, and you open it up to it being the insurer, the government, even the clinician, who is the payer. Firstly, they have deeper pockets. Secondly, they get you access to a much more reliable and stable network instead of having to go to individual clinicians or individual people. Thirdly, because you're in a clinical context, my contention is, and I don't have proof of this yet, but I hope to prove it soon, the data you're going to collect is going to be of much higher quality, which is, of course, important if you're trying to do artificial intelligence. If your clinician believes in the application and is telling you, listen, in order to choose the treatment I need for you, I'd like you to go home and use this app for a week or two, then you actually have a context in which it makes sense for the patient to use the app. Because as you all know, retention of people in using applications is very, very, very difficult. It's a very hard point for new apps to make when you have such a very big and crowded market. But if you can make your app the one that the clinical environment recommends, that is part of the clinical program that the clinic uses for all of its patients, then you start to get a situation where you have reliable data incoming. Now, what should you develop for us? There are so many things. I mean, I'm going to go through a list, but I think you all know everything that everybody's working on. So, you know, you've got classifiers for diagnosis. This is the thing everybody talks about. Can we diagnose people better? We have recommender systems for treatment selection. We have reminder or early warning systems. There's quality control systems. Let's say if you had a medical record and you're using NLP to read through it to make sure the doctors are actually using good quality medical records. Prognosis systems. So, okay, patient had a stroke. What's the likelihood that they're going to get better? Imaging analysis, of course. Patient symptom tracking and prediction. If a patient just got better from depression, let's say, can I track their movements? Can I track their answers to questions, et cetera, to see if they're going to relapse to another depression or if something else is going to happen. Patient flow optimization. Patient flow in hospitals is very complicated and is done by humans most of the time, which means that it can be very difficult to keep in mind where everybody is and where they should be going and when an operation is, and just scheduling is a nightmare. And this is obviously something that could be optimized. So, lots of different applications. And this is the point I was making about replacement versus augmentation. Replacement can be useful for some tasks. It never, ever should impede on the physician-patient relationship because honestly, that's actually an important part of healing. Who here has been to see a doctor ever in their life? Everybody. Okay, good. Who here has had a positive experience with a doctor at some point? Okay, that's better than I was expecting. Do you feel, who here has had a negative experience? Okay, good, about half and half. The people who had the negative experience, do you think that negative experience impacted on your ability to get better? Ideas? Yes? Can people nod awkwardly, maybe? Or shake their heads awkwardly? No? Okay.
It's very hard to say, basically.
No, it is. I just want people's opinions because the research showed that it definitely does. Mm-hmm. The research is clear that it does. I wanted to see if people had that sort of intuition. But the research is clear that the patient-physician relationship is actually a very important part of healing. And you do not want to start having an application that's coming in and that's forcefully, pushing people one side or the other, and the patient's coming in says, this says I should have this. And the doctor says, yes, I know it says you should have that, but it doesn't take into account this, that, and the other. And if I give you this, I think it's dangerous. And then the patient says, then I don't want to see you anymore. And then they go see another doctor, and it can be a mess. You want to make sure that your applications aren't actually hurting that relationship, because guarantee you, that relationship probably has more value than whatever it is you're trying to plug in with your application. You want to augment and strengthen that. That doesn't mean you should reinforce physician bad habits. You should try and fix a lot of the terrible habits that we have, and we have so many of them that I could just go on for hours and hours. But you want to try and intelligently subvert those bad habits, not bludgeon them because it's going to cause problems. Augmentation and huge potential, which we've been talking about. And the way to get around this is to engage clinicians and patients in development. If you haven't spoken to a clinician or a patient in your development process, you're wrong. If you've only spoken to one clinician and one patient in development process, you're wrong. If you have no clinician on the team or as an official advisor, you're also probably wrong. You need to get this domain expertise into your team, and you need to get your team out to go see that domain expertise. If you're developing something for an emergency room, go sit in an emergency room. See what it's like. Get a sense for what your data means. Because if you don't understand that, you can have all the data in the world, but you're not going to be able to use it appropriately. And if you cannot use data in context, your application is doomed to fail. Oh, and one little point. Keep your interfaces really simple because we don't like complicated UX, because already the medical records we use are horrible and ugly for reasons I don't understand. And it makes our lives difficult and miserable. And also make them fast because we spend a lot of time waiting for things to load on computers. Data quality. This is a very important point, which I think has probably been talked a lot more about now than it has been in the past. But it's really important when you're talking about building AI for clinical applications. It's really important to remember what data you're collecting, if it's reliable, and if you can actually use it to solve the problem, answer the question you're asking. Good performance isn't enough. In fact, if your performance is too good, you want to question it. Because if it was that easy to figure out which patients have what, we would have done it already, right? So you have to sort of be very critical of the data that you have and try and understand where it's coming from in its context. So let me give you an example. I think this is the next example. Okay, we'll go there in a second. The point about bias. So I'm sure you must have heard about the algorithm in the States that was doing prediction of who's going to reoffend a crime after they were in jail. This is the classic example. I use it because some people know it. Who has not heard that example? Okay, good. So some people. So basically, they were using an algorithm in the States. I don't think it was a particularly complicated algorithm, but they were using an algorithm that was trained on data from inmates, prisoners who'd been let go from jail and who had committed another crime. And they were using this to help decide whether or not new inmates who were up for parole should be allowed to leave jail or not. And basically, their data was biased. Almost all their data came from African Americans. So the algorithm said, if you're African American, you're probably going to reoffend. When in actual fact, if you look at all the data, whites and African Americans had about the same reoffense rates. So people were put in jail and kept in jail unnecessarily on the basis of an algorithm that was trained on biased data. That is not good. That is a data sin. That is how you can hurt or kill people with data science. You can hurt people. Your applications can cause harm. And you have to be aware of that, especially if you're in the medical field. And it's not something I think is said enough, is that these are going to have impacts on the lives of real people, and people will learn to trust your algorithms because it's math. They think it's objective. So they'll trust it, they'll do what it says, and then they'll hurt people because of it. So you have a responsibility to do the science right. Let me give you another example. Who really wants to get access to a lot of medical records? Why? Why do you want to get access to a lot of, what are you trying to build?
I hope more data is better data.
Okay, but what are you trying to build?
We want to build a depression therapy resistance warning system.
Okay, very cool, good. That's actually similar to what we're doing, interesting. We'll talk about that. What do you want to build?
Well, I'm actually just getting information about how prevention and stabilizing techniques can help in different mental health
Okay,
procedures.
interesting. What do you want to build?
I worked on predicting tumor growth in the brain from different computer scans.
Okay, cool. So for classic medical records that are available at your average hospital, the only of those two that will actually work is hers, over there. For the simple reason that scans, assuming they're good quality, which is not always a good assumption to make, assuming they're good quality scans, and assuming you have good radiologist report, which is also not a good assumption to make, but assuming those two things, you should be able to do that because it's longitudinal data. Each patient usually has multiple scans, and you should be able to make predictions based on demographic factors plus the imaging qualities. Mental health data. Unless you're getting mental health data from very good clinics that keep very good data, it's the worst data of all medicine. It's terrible. It's horrible. It's horrible. This is why we basically said we're not going to even bother trying to get hospital data for mental health. For multiple reasons. Now, it might be different in Germany, but in Canada and the United States, doctors do not keep track of outcome measures. They do not keep track of how well a patient is getting, how well they're doing. Now, if you're talking about psychotherapy, it's possible the therapists are usually having scales that they use. But you have to be very lucky to get the right kind of N for that, right? Yeah, you know what I'm talking about. Good. But on the whole, if I went to my local hospital and they said you can have all the medical records, and we'll even pay for you to digitize all of them because most of them are paper. But let's say they won the lottery and said you could digitize all of them, and I would say, can I have the money instead? Because I know the doctors do not keep track of patient outcomes. I have no way of really saying when a patient has gotten better or not. And I have no way of differentiating if a patient has gotten better or just left services or moved away or et cetera. It's very difficult to say. And a clinician will write different things depending on how they're feeling. So if I'm before lunch, I will say, patient improved, continue same treatment. If I'm after lunch, I'll say, patient looked good, I'm tired, continue same treatment, we'll see in 2 weeks. If it's the morning and I'm excited and bright, I'll say, I'll write a half-page note about everything the patient has done and all the things that they've done and how much better or worse they've gotten on different indicators. So the quality of the data is actually terrible in a lot of medical records. And so, because of that, you have to have a deep and practical understanding of the data sources that you have, otherwise it's garbage in, garbage out. Because if you want to predict, for example, readmission rates to the hospital, you might have some information, but you will not necessarily have all the information as to why they were readmitted, and you might not be able to catch the subtleties of each case. You might not be able to catch the demographic reasons, the sociological reasons that might have led to that, and you might make false assumptions about the links between different variables. And then that leads to you trying to make interventions on those variables, and it's actually the wrong intervention to make, because it's not that variable that was really important, it was something else that you didn't capture in your data set because doctors don't capture it. So medical records are actually not a very good source of data for a lot of applications, but a very good source of data in other applications. So it depends what, right? Yeah, so if your data is not right for the job, and before you think it is, actually have a look at it. Like, look at the records. Look at what you have to work with. Speak to doctors who make medical records and who keep records. See, because very few doctors don't have incentives to keep good records. We don't. All we have incentives to do is to keep records of anything terrible that's happened so we can't get sued. That's it. Beyond that, we don't have much of an incentive to keep good records. Yeah, so if your data is not right for the job, you better stop and rethink what you're working on. And a lot of the time, what I find interesting is that in most of science, if we have a question, we design a data set, we run an experiment, or we even do a longitudinal study, and we just gather data that is fit to our purpose. And in the data mining craze, we've sort of just come to accept that the way to go is to just mine all the existing data without regard to its quality. And more N does not actually equal more quality if you've just never been collecting any of the variables that are important to begin with. So be careful about the data that you're using. Interpretability, this is a fun one. So what I like to talk about is the fact that we are shooting ourselves in the foot often by calling things a black box. Black box this, black box that, black box this. It's not actually a black box by necessity. We call it that as a euphemism. But really, a neural network or any other kind of AI technique, but we'll talk about neural networks because that's what everybody's excited about now, can tell you quite a bit about the information that it's using to process. It might not be able to tell you about every single nonlinear relationship that it's using, but it can tell you things, for example, like for this patient, these features are most important in making a decision. And I'm going to show you why that actually might be enough. If you develop standards for interpretability, if you develop ways in which you can present information to clinicians, and you standardize that and you do it, in a consistent fashion, clinicians will sort of start using that and understanding that, take it into consideration, just like they would information from a colleague or from a paper. Often the research that we produce in medicine does not have causal mechanisms in there. We don't know the causal mechanisms for plenty of things. We know risk factors for a lot of things. Well, sometimes we have no idea why something is associated with something else, but we accept it because it comes from the literature and it's been replicated, etc. So if you can provide us with information, even basic information about the low-level inputs to your network and why they were and how important they were, that can help us understand. And another thing to think about is it doesn't stop with your application. The features that you find are important for different subgroups of patients, for example, are interesting research questions that you can then go and give to the medical community and say, hey, we found this. Can we work together to figure out why this might be from a causal perspective? And then you create research collaborations that further improve the validity and credibility of what you're building. So this is what I think engineers think doctors do. This is a note written by a medical student that has beautiful detail. It has everything. It has how old the patient is and what their dog is named, etc. It's like very, very detailed and exactly why this medical student thinks the diagnosis is X, Y, or Z. This is what we actually do. Okay? This is the information that we give to our colleagues. It says, I think it says somewhere in there there's an age, and then it says rule out active bleeding, rule out stroke, do a CT scan. So this is what I get into in the morning from the neurologist when I call them. I go off of very basic information that they give me. They say, okay, the patient's this old and they have this and this. do this. They don't say, because the patient is this old, it increases the permeability of the blood-brain barrier and increases the inflammatory capacity, and therefore there's a higher risk that this patient is bleeding, so I wouldn't put they don't say that. Because if they did, they'd probably be bullshitting. That's the first thing. And secondly, even if they weren't, it's 2 in the morning and I don't really care. I just want to know whether I should do the scan or not, right? But I do want to have some semblance of understanding basic risk factors that are kind of common knowledge amongst all of us. And so if you can produce a system that can produce sort of basic information for clinician and put it in a report format, that is very helpful. And we can learn to work with that. And that is something that Aifred has been doing. We are able to produce reports for a given patient. What were the questions that were important in helping predict whether or not they would respond to a given treatment? And when you look at the inputs, they make sense. And they're interesting. And a lot of clinicians will say, oh, okay, so I see. It's because this patient was particularly, has particular psychomotor agitation, or they're suicidal, or they're this, or they're that. And at least it gives some information they can use to start thinking about the case a bit more deeply. But it's not just a number. You have to give them some kind of information. So, safety. As I was saying before, your applications can kill people. And it's not all about data security and privacy. Everybody's worried about data security and privacy. It's important. It's very important. GDPR and all that stuff, very important. It's not the only mistake that you can make. Safety basically means that before you put something into the world, you have to be sure that it's actually doing what you think it's going to do. And you have to be sure that it's actually producing the effect you want it to produce. And you have to be committed to measuring that effect because it's going to change the way people practice. So there's this concept of endogenicity that I heard about recently, and it kind of summarizes something that I've been thinking for a while. All the data you've collected before your app existed is data before your app existed. And the timeline will split when you implement your app. There'll be 2 futures, one future with your app and one future without your app. The data in the future with your app is different future than data in the future without your app. Because it will change people's conceptualizations of the illness. It'll change people's understanding of the system. It'll change the way the system works. It'll change availability of resources. It'll change the prescription practices of doctors. It'll change a lot of things. It will actually potentially fundamentally change the actual patterns in your data and the way they predict future outcomes. So you're going to have to continuously update your algorithms, especially if they're very personalized, because what you have done is you've perturbed the system. Which is why it's not enough to say, okay, based on this medical record set that I have from the last 20 years, I can predict depression remission rates with this much accuracy, and therefore it's good enough, and I can put it in the world, and it's just going to work. Because actually, things changed when we put in antidepressants. People's understanding of mental illness changed, and that probably changed the way they respond to their doctors and they relate to treatment, etc. And the way you feel about your treatment when you have a mental illness actually impacts significantly, research has shown, on the way in which you get better or don't get better. So the only way to really know for sure is to actually do a trial where you are testing your algorithm as the intervention. Your algorithm is basically a digital drug, even if what it's doing is actually recommending real drugs. And you want to see what effect it has on doctors, on patients, and on remission rates and whatever else you're trying to target in real life. Great. Okay, so clinical validation. Basically what I said, accuracy measures are useless in isolation. The numbers don't matter unless you clinically validate it in clinical trials. So in Europe, it's necessary anyway, because that's the law. In North America, it isn't. Health Canada told me, you can do whatever you want. We don't care about AI, clinician decision support. So I could actually build my model and then go out tomorrow and say, here, doctors, use it. We're not going to do that because we don't think that's the right thing to do. We think it's important to get it tested and piloted first in the real world under controlled conditions before we release it. And you also want to see not just is it safe, is it effective, do clinicians actually use it? Because at the end of the day, you're building something that has to be a product. It has to save somebody money for them to purchase it, right? And even as a clinician, I understand that. I understand the need to build something that's actually going to be useful to somebody in a very utilitarian sense. If clinicians don't use your product, even if it can predict things 100% accurately, it's a useless product. It's not going to change the healthcare system. It's not going to change outcomes. It's not going to improve cost ratios. It's not going to reduce costs of care. It has to be user-friendly. It has to work in the actual environment. And we said this already. Okay, good. So do the science right is my basic message I want to get across to you today. And it's not just about the data science. It's about the clinical science as well. Blah, 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 blah. Okay, next. Well, I can skip this, but basically selling to doctors or to clinicians is all about a few things that we've already talked about, making sure it works within our clinical workflow. If you don't understand how a doctor works, ask to go and shadow a doctor and watch them work. Because we might not work the way you think we work, and different kinds of doctors who you've never been to see yourselves before might work very differently. A surgeon, believe me, works very different than a psychiatrist. I sometimes think we're different species. A family doctor works very differently than an internal medicine doctor, who works different than a cardiologist. Our workflows are different. To the point where, when I mean workflow, I mean literally, what is the flow from the patient entering the waiting room? Do they see a nurse first? Do they see the doctor first? Do they get weighed? Do they have their blood pressure taken? These steps actually matter because what clinicians do not like is change. We do not like changing the way our flow works because it takes a long time to get comfortable. When we get comfortable, we don't like to move. Okay, we're like mollusks. We don't like moving. So you have to figure out how to make your app work within our workflow and make it work within the patient's daily life as well. And this is keeping in mind the kind of patient they are. Because a depressed patient is going to be very different than a patient who's had a surgery, who's going to be very different than a patient who is taking medication for diabetes. And depending on the kind of diabetes, it's going to be very different. Their lives are different. Their rhythms are different. You have to keep that in mind. You're not going to have one application that fits for everybody. You have to keep that in mind. You have to build things specifically to specific solutions. And make it fun. Okay. Oh yeah, we also won't trust you unless you show us clinical data. Like we really will not trust your applications unless you say, we did a trial, here's how we did the trial, it was a best practices trial, it was run with academic partners, and it worked. And here's how it worked. Okay, so let me give you a practical example of all this. What time is it? Okay, good. Practical example of all this, and then we're going to go to the ethics stuff, and then there'll be some fun activities, okay? Are people still awake? Good. Okay, good. So what do? Basically, Aifred Health, our company, is trying to do something simple. We understand that clinicians, physicians, psychiatrists, are very bad at knowing which treatment will work best for which patient. Whether this be drugs or psychotherapies, etc., we're not very good at personalizing treatments. And that means that we actually have a situation in which most patients do not get better after the first treatment, regardless of what kind of treatment you try. Okay? And there are lots of different kinds of treatments, so it's not like we only have a few things to choose from. We have like 20 medications and 5 main psychotherapies and 3 different neurostimulation techniques. There's lots and lots and lots of variety, and we have no way of personalizing that treatment in a principled way right now. So what we said is, this is a problem of complexity. We know that some people do better with certain things than others from our clinical experience, but we have not been able, with classical statistics and group level comparisons, to actually figure that out. So let's use AI to make some individual level predictions. We have some validation that this works, but the basic concept is taking in patient information at the individual level, talking about everything from their socioeconomics, their symptom profiles, and we're going to be moving to biomarkers as well, putting that together and using it to predict response to treatment, to a number of different treatments, and then predicting confidence for each treatment, and then letting the patient and the clinician decide together what that treatment should be. And then monitoring it afterwards. That's not our focus right now, but we are going to be monitoring it afterwards to see, is the treatment in fact working? Should we change the treatment? Do we think we want to add psychotherapy now? Do we want to do other things? And so our approach so far has been really to focus on very high quality data. So we've gotten access to clinical records from pharmaceutical companies, from open data initiatives, from researchers around the world who give us their data so we can analyze it. And it's good data because it's clinical trial data. It's data that has a lot of information about the patient at baseline. We know exactly how long they were treated, how long they were treated for. We know if they dropped out of treatment. We know the side effects they had. We have all the information we need. There is problems with that data, which is that it's not always representative of the population. Clinical trials, especially if they're run by pharma, are often not representative of the general population. So what we're planning to do is, once we've understood the kinds of things that seem to be important in this data, we're going to be expanding our data set by collecting our own data through an application that will be sent to clinicians for free. And it's a rule-based application that helps clinicians use existing evidence, existing best practices to treat their patients with depression. Most clinicians do not use existing best practice because they have to go look at a paper and follow a complicated organizational chart. So we're making it simple for them in app format. They'll use this and it'll collect data in a very structured way that is going to be useful to us to then be able to expand our models and produce a fully sort of AI-powered version of the model that can make predictions about different treatments. And that's sort of what we're trying to achieve. And it's important because depression, we're starting with depression, but it can apply to any mental illness, is a very, very common problem. It's a very severe problem. It's 11% of the population globally. It's the largest cause of disability on the planet. It's 300 million people at any given time. And it's $210 billion to the US economy. And it's expensive at an individual patient level for the patient, for the insurer, and for the clinical provider. So we actually are able, if we're able to reduce the amount of time it takes to treat a patient, if we're able to reduce the number of failed treatments that a patient might have, we can actually be in a situation in which we're saving money to the people who are actually paying for the care. So there's a business case for the people to actually use our system, so we can collect more data, so we can continuously improve it, and so we can provide updates in a SaaS model to our clients. And that's kind of the model that we've been taking. What we're doing is that we're actually developing this application actively with clinicians, myself, but also others. And we're building it to be a solution that is usable by the clinician and the patient together. So the patient does not get a list of recommendations and drug dosages for lots of reasons. Like, for example, we want to avoid patients going to the Silk Road and just purchasing lots of drugs and then getting sick, and then it's our fault, right? Because that's the only way they can get a prescription without a doctor. What we can do is we can collect information, we can empower the patient by giving them access to the information about themselves so they can track their own progress. But for the predictive analytics, we put it in the hands of the clinician so that it enriches the patient-clinician decision-making. And we're actually going to be prompting the patient to discuss the options with the clinician, to discuss the options with their patient, and so they can compare things like side effects and likelihood of working and make a decision together. And we think that's going to really empower patients and clinicians to make better decisions. And this I've said, I'm going to just blah, blah, blah. Good, so this is kind of what it's going to look like. You have a bunch of treatments, and then you have the likelihood of efficacy. This is just a mock-up, of course. And then you have the drug name, you have the factors that went into making the decision so that we know that this patient was, because they were psychotic and because they were male, let's say this drug is better. And then side effects personalized to the treatment. And it's sort of built into a nice sort of interface that has a bunch of other features that clinicians want. We will be using different kinds of deep learning technologies. We'll be eventually using multi-objective learning because we're trying to predict multiple treatments at the same time for the same patient. And we use unsupervised learning as well at the beginning part of the training to get a better sense of the underlying data, kind of like a medical student who goes through medical school and then actually gets tested on specific things. And the basic loop is that the clinician and patient speak together. They both put in information, the patient before the session, the clinician during the session. The information goes in to the sort of application. The application then goes to our deep learning network that is, we call it Vulkan. It was something we developed in-house because we like Star Trek. Then it goes to a treatment suggestion that goes back to the physician. They make a decision together, and then we monitor outcome, and we make suggestions as we go. And we're going to test this not just by the classic test measures, but also by clinical trials. This I told you about, blah, blah, blah. And how are we different? We're really focusing on treatment and not on diagnosis. We're not saying that depression is especially difficult or complex to diagnose, that we need an AI for it, because there's plenty of questionnaires that are easy to fill out that diagnose it fairly accurately. What we're saying is that the complexity comes in the actual treatment selection. And this is important. You're picking a problem that is specific. You're not sort of saying, we want to help depression. We're saying within the treatment of depression, what are the pain points? You identify a pain point and you go after it. We keep the doctor in the loop instead of it being direct to patient so that it actually gets implemented into real clinical practice and makes a difference in the lives of patients. We try to identify what kind of information is best gained from the doctor and what kind of information is best gained from the patient. We focus really heavily on good data quality, clinical validation, and this gives us market staying power. And the profit model is basically that it'll save money to insurers and to service providers, so it incentivizes them to purchase the product, and it also helps them gain a competitive advantage and attract patients when you're talking about a private healthcare system. And in public healthcare, it just helps you provide more care to more patients with less cost within the same budget, and it will hopefully reduce rates of relapse, because patients who have depression are likely to have depression again. The longer they have depression, the more likely they are to relapse. If you can treat them faster earlier, then you can potentially get to a situation where they're not going to have another depressive episode for longer. So how you do a clinical trial on an AI system? We'll go through this fairly quickly because I want to get to the ethics stuff. So the first point is that efficacy is not equal to effectiveness. So these two words mean two different things in the medical literature. Efficacy basically means how well your solution works under ideal conditions, and effectiveness is how well it works under real conditions. So obviously you want to know that your application really works because your application is good, but you also want to know that it works in the real world. And you need to understand both. And you have to demonstrate your safety. So you have to go through actually a number of trials to demonstrate both of these things. And you have to reassure everybody that the software is not going to have unintended side effects, like making doctors even lazier than we actually are. So let's talk about how you design these trials. So the first thing we're going to do is an ease of use study. So this is very simple. This is just to see if doctors are able to use the damn thing in simulated practice conditions. So we're going to train them to use it, not extensively, but in a simple sort of training that actually makes sense. They'll get 3 simulated scenarios with simulated patients, hopefully. They will then give us feedback, and we're going to observe them and see how they do while they use the application. And basically that will tell us, is it usable? Do doctors trust it? Do doctors actually predict or use the recommendation of the system at the end of the scenario? And it will help us get some basic metrics on the usability of the application. Next, we're going to move to an open label study. An open label study basically means that the intervention, which is the algorithm, is known to everybody. So everybody knows that the algorithm is being used. There's no blinding, and it's not something that we hide from people. This is important because I don't think that people will actually feel safe signing up for the study until they know that this thing doesn't cause harm. So it's important to run an open label study first. Also, an open label study is nice because since you're not under blinded conditions, it's much closer to real life. It's just basically saying, here, doc, use the tool, see how it goes. You don't constrain the doctors to have to use the tool. You just say, here it is. Tell me, use it if you like, basically. You randomize the clinicians, which is important. So you're not blinding them, but you're randomizing them. So you're saying, I'm not going to have all clinicians from one hospital use it and all clinicians from another hospital not use it, because that might introduce bias, right? You want to randomize the clinicians, get an equal number of psychiatrists and GPs here, female, male, old and young, so that you don't have all the old people on the technology side, they don't know how to use it and then it doesn't work. And then they get to use this on their own patients. And then you just sort of compare a group that gets access to the model and a group that's just doing practice as usual. And then you see, just basic outcomes. Are there more side effects or less side effects? Do patients generally get better or worse, more in one group or the other? And the physician gets to use the treatment. You do standard statistical tests and you report that. And that at least tells you, are you making anything worse? And are you potentially having some kind of efficacy in the real world? Effectiveness in the real world. And then this is the gold standard, is the randomized clinical trial. The randomized control trial, sorry. And this one is the one where you blind people. So once you've decided the thing is safe enough to use in a randomized control trial, you randomize physicians again, so you put them in different groups, and then you blind them. So you tell them, I'm not going to tell you whether you have the AI or a dummy model. The dummy model will just give you best practice guidelines, so whatever the evidence says, and the AI model will give you the highly personalized recommendations, and you don't tell them which is which. And because the AI model, by this point, hopefully will have seen if it does things that are ridiculous, it shouldn't, it should still give you treatments that are reasonably recognizable to the clinician. And then you do a third group, which is basically just, again, practice as usual. Why do we need 3 groups here? Because these 2 groups are blinded and this one isn't. That's important because the 2 groups, that one who has the dummy model, one who has the AI model, are still both going to have lots of measurement going on. And just measuring by itself helps improve the quality of care. So you really want to get a sense of what's better. The AI versus the guidelines versus basically practice without anything added on. So this tells you if just measuring and acting according to the guidelines is better, and then this comparison tells you if your AI adds something on top of that. And then you're actually able to say, my AI has this amount of effect, which then gives you a really strong selling point and a good sense of the actual efficacy, so how good it works under idealized conditions. And then the same thing, you test it in the same way. So now we're going to play a little game, but before we play a little game and change tracks, I want to see if there's any questions so far. Question?
Sort of, I was wondering, you kind of spoke about this in the beginning, but if the general idea is kind of like outsourcing processing power, because reasoning is becoming way too complex and all these facts and all that, how do you see doctors actually accepting the machine's answer? Because they can't really figure out how it got there and understand all the processes and all of that. Like even if maybe society really trusts this or there's research to back it up, they're probably not familiar with all the technical details. And I mean, you're a clinician too. How would you feel about using something like that?
Well, I mean, I'm biased because I'm trying to build myself, but aside from me, we already do it. So for example, when I want to decide whether a patient should get a CT scan, the first thing I do is I fire up the internet and I go to the CanadianCTHeadRules.com, and there's a little calculator and it asks me questions and I just put the questions in and it says, yes, do a scan, no, don't do a scan. And I trust it. Because there's a clinical study that showed that 99% of people who were under this threshold didn't need a scan. They scanned everybody and they saw that these people didn't need a scan, right? So is it perfect? No. Is it probably better than my intuition? Yes. And I trust that because I trust the research that was done. So we're used to doing that. So all we're saying is, you already didn't know how to make that prediction. We're just coming along for an even more complicated problem, making a more complicated prediction. And just like the Canadian CT head rules, we're going to tell you what those features were that are important in making the decision, but it's going to be personalized to your patient instead of being general. And so it is a little bit of a shift, but it's not a drastic shift because we already do this all the time. Because we know that we can't guess everything. And we know that without referring back to the research, our individual practices often do worse. But this is why it's important to have the validation, because you actually have to be able to say, yes, in fact, this has been shown to both be safe and effective. And if, the thing is just helping you make a decision between 20 drugs, any one of which you could have prescribed on any given day, it's not really putting you in a position where you are, you're not deciding whether or not to send your patient for deep brain stimulation implantation right away. That would be a bit of a harder sell. But you are, maybe if you have to decide between psychotherapy or drug Y for this patient, they're both good treatments. So if it tells you, and you don't really know, the psychotherapy is going to be really good for this patient, the drug's not so much, why not? And a lot of clinicians feel that way, that we've spoken to. As long as there's clinical validation and we can give them some kind of intuition as to why it's happening. Any other questions? Yes?
Just from the business point of view,
Yes.
I was wondering what's in it for the hospitals? Why would they be willing to license it?
Save money.
Yeah, but if, for example, the benefit that you get is that you would be more accurate on treatment, so it would take smaller time. But for the hospital, isn't it the same? Because if a patient takes longer, he still pays for it.
No, it depends. So it depends on the system you're in, right?
Okay.
So, for example, some hospitals, if you're government run, you get a budget, right? And you have to fall within that budget. If you fall outside of that budget, they take funding away, actually. And they punish you if you fall outside the budget. In other situations, it's a question of patience. You get a higher satisfaction rating if you're in a private system where actually patients pay. You actually end up looking better than your competition. So regardless, there's usually an incentive because there's not a lack of patients. We're not in a situation where there's only a certain number. There's more patients than we can treat right now. Yeah, it's a supplier's paradise kind of thing.
We had this discussion because we're doing something really very similar. But we're doing it with Bavarian data, Bavarian studies, because we say it's very region dependent, especially if we're talking about psychology and psychopathology. So this is obviously a lot of Canadian studies.
Canadian, American, and European.
Yeah. So do you think this also accounts for European patients?
I think, especially for the drugs, for sure. For psychotherapy, we'll see. I think it probably will, because the paradigms that are used for psychotherapy are not that different across North America and Western Europe, at least. There are some regional differences, but that doesn't necessarily mean that the efficacy of CBT in that population, let's say you're in France and everybody does psychodynamic psychotherapy, right? Everybody's doing psychoanalysis. It doesn't mean that CBT won't be effective in that population, because it's still a population that is fairly recognizable. That being said, we won't know until we test it. So the psychotherapy is a bit iffier. I'm definitely not going to extend this to, like, Africa or South America. I think that would be inappropriate. I think when you're talking about places where cultures are fairly similar-ish, then you might be okay. But our policy is actually going to be to do a regionalization process in every region before we employ the AI, just to make sure everything works. Yeah.
But do insurance policies impact the way the treatments are done? And, I mean, this varies from country to country.
Yes, though a lot of the basic treatments we're talking about are covered almost everywhere. So it depends, but for example, the big difference would be psychotherapy. So in a lot of places it's not covered. But what we can say is, listen, we're making a list of treatment suggestions. If we consistently suggest psychotherapy over other treatments that are covered, the clinician can always choose one of the ones that's actually available, right? But we can then tell the administrators of the hospital or the region or whatever it is, listen guys, if you were to have psychotherapy covered, and maybe not focus so much on making sure that these 3 drugs that are never ever used are covered, maybe you might actually do better. So we might be giving some information to administrators that would help them make decisions about resource allocation in the future. So it does depend on region. At least for the drugs, thankfully, most things are covered in most places. But for psychotherapy, it does vary. But it doesn't mean, again, that assuming the patient characteristics are similar, that they shouldn't have access to that. So it's a good argument for improving access to certain treatments if it comes up on top of the list often. Yeah. Go ahead.
That would mean introducing a new drug would require that you train all the models beforehand, before you launch the product.
So if you wanted to introduce a new drug in the future, yes. It would be part of the update. So you would have the old model, you would have to update it with new data for the new drug, and you could potentially, if you have a large enough install base, you can you can test on a few different pilot groups and just make sure that it isn't causing any issues, and then you can do a wide release. But once you already have that install base, it makes it much faster to do revalidations of your model. Yeah. Other questions? Okay, cool. So we're going to play a game, and the game is, do we have time for the game? We have time for the game. Okay. The game is, we're going to ask you guys to think about some ethics, because what is sort of in the background of all this is ethical considerations. We haven't really talked about it all that much, though we did touch about it a bit in the beginning. So let's say you want to develop an application that can predict suicide attempts. Okay? We're going to split into groups. So you guys over there will be a group, and actually just everybody in the back there will be a group, and everybody in this row will be a group. So in the row of the guy with yellow shirt, and everybody in this row will be a group. Yeah, okay, it's big enough. So we'll do 3 groups. So back group, this row, and then this row. Okay? And basically, what I want you to do is, here are some guiding questions. You're developing a suicide prediction tool, and you have to answer questions. What are some concerns about building a tool like that? What are some benefits, potentially? What might some of the algorithmic challenges be in making a prediction like that? Who would be the end user? Is it the clinician? Is it the patient? Is it family? Who is it? And why, from an ethical standpoint? What kinds of problems do you predict with developing something like this? And how could you mitigate them? And what kinds of problems would you see happening if you actually deploy this in some market? And how would you mitigate them? And what approach would you use to think about the ethics of this kind of system? So you have 7 minutes, and I want you to think about it. Okay. Thank you, guys. So we are going to go one by one. So everybody listen to all the groups. Guys, good. So we'll start at the front and then go towards the back, and then for the next time we'll do the other direction. So why don't we start over here? Why don't you guys tell us a little bit about what you were thinking? Somebody volunteer or I'll kick. 3, 2, okay, go.
So our concern was who should use this app.
Okay. What did you think of?
One of us said our family can enter our information and see if they are suicidal or not. But then there are some questions would be ethical. Because maybe I don't want to share this with my family, with my friends, or maybe they will just be paranoid and enter whenever they see us sad, and it will cause some problems in our daily life. So we don't want this. So I guess the end user would be clinicians.
Okay.
Other than that, there are some ways to collect the data. And I don't know, the algorithm probably can be the classification problem, because if you know all the age, the family problem, how stressful their lives, so we can just predict, but how good this prediction will be.
And how does one test it?
Yeah.
It's an interesting ethical question.
So this will be a
Prospective study of suicide conclusion. Yeah, that's not going to fly by any ethics committee.
I guess that's all. I don't know if you want that.
Cool. Any other thoughts?
For me, the main thing was thinking about maybe what approach to use to think, but more what were my criteria to think. What are actually my ethics about it? Because we had some people saying family. For me, that is a total no-go. I had a friend who just killed himself.
I'm sorry.
And that was, yes. I hope he wouldn't do it, but he actually talked about it for years. And he did it. Still, so the question is actually, what do we think is ethical? For me, it's if someone visits a clinician, then it's absolutely okay if a clinician uses the tool maybe to predict suicide attempts, but the idea that the family might check on someone is for me horrifying. And the question would be first to, how can we think about this? How can we decide this? And so basically the other questions for me, I could never really start thinking about them. That was the first thing which I'm really not swimming in. I have no foundation.
Yeah, no, absolutely. This is a very important point, the no foundation point that I'll make a little bit later, but we're entering in an era where these things are possible.
Yes.
Right? So we're entering a point in time where we have to start finding some kinds of foundations upon which to stand, or else it's just the nuclear bomb all over again.
I need to admit that I never thought about all this, and I have no personal reference, but I saw a value that if you could predict the suicide of a pilot of an airplane,
that is very topical, yeah, relevant especially.
We had the discussion, the public discussion, but listening to the guys, I also got skeptical whether this is ethical.
There's another wrinkle to it. Well, I'll add that after. Let's see what this group has to say.
Okay, well, one thing that we talked about a lot is that one of the algorithmic challenges would be that it's kind of hard to find objective data, in the sense that if you get some sort of input by the person, most people aren't really that self-aware, and as someone who's probably a little bit depressed, which is why they're using the app at all, well, first of all, like, maybe they would kind of want to avoid that they have an issue at all, so maybe they wouldn't even use the app in the first place on their own. And then probably they're sort of in a phase of their life where they're not so connected with themselves, and maybe their reasoning ability is a little bit skewed because they're kind of scared, and so they probably would not input exactly the truth. And then we were kind of thinking about how we can mitigate this, and one idea was kind of gathering data from their online activities, maybe tracking their location. Like one idea was trigger detection from like maybe them walking past the liquor store at a certain time during the day and going in there when their Facebook activity has been of a certain type, something like that. Then again, that doesn't really reflect their, well, I don't know, but might not really reflect their inner thoughts as much as their coping mechanisms. So it's kind of hard to really get objective data on how they're feeling.
The coping mechanisms are often very relevant in terms of what we end up doing. So, but a really good point. Yeah. Other thoughts from that group? Yeah, go ahead.
I mean, we can actually also have this we can also have this two-level end users. One of them would be one of them would be the patient, but then the app on that patient's phone would actually only collect the information, and the other app would be on someone who can actually just detect the problem and then just call for the necessary authorities to prevent the situation. And then that could be, and then actually there could be this, like the security overrides from the second user over the first one, and then therefore, like when the suicidal person doesn't feel like he's suicidal, but let's say the clinician actually knows that he's about to commit suicide, then we should be able to override it too.
So this is a very interesting wrinkle. This is actually the wrinkle I was talking about before, is the legal requirements. So if I think a patient, in my professional opinion, when I see a patient, is imminently suicidal, I am required to, and I have the power to take them and put them in the hospital against their will for up to 3 days without asking the judge in Canada, right? So the question then becomes, and we're not going to answer this now, but the question becomes, what is the legal implication of having an app that with 90% or 95% or 92% or 85%, and the number matters obviously, accuracy can predict whether or not someone's going to commit suicide? Does that automatically mean the police has to go to that person's house, arrest them, well not arrest them, but bring them to the hospital potentially against their will? It's an interesting thought because that would be the natural extension of the current rules.
I mean, there could be levels of different interventions. So then if the individual's data actually shows that it might be some sort of a false positive, then you only take the preventive measures on a really light scale, and then if it really sounds like a true negative, then you just grab that person and put it in the hospital.
Assuming that we can detect and understand the false positives.
Yeah.
And the group in the back. Come on, guys.
Well, we thought that the hardest part, first of all, was to get clean data. With what kind of data are we working? Get the data not to be biased, because, like, I think, especially in my opinion, if you don't have clean data, you don't have to start at all. Like, if you don't have sufficient data that can help you, then you don't really have to focus on the West, because your app is not going to work.
Other thoughts?
Most of the things have already been talked by other groups as well, but two other things that we were thinking was, one was that what would be the effect of wrong predictions by our application. I mean, not just in terms of if we put the person in the, just on the basis of app, but how would it affect the thinking of the clinician who sees it? Like, how does it bias his opinion? Maybe app says there's 0% suicidal chance, and clinicians say, okay, there's no chance, but that can happen.
Yeah, that's true.
And second thing is basically the data security, because it could be you have the data on the suicide possibility of a lot of people, and if it gets out into the wrong hands, this could be really bad as well.
And in people's careers.
Yeah.
Yeah, absolutely. Great points. So I think now we have a choice to make. We're out of time, but I have a bit longer left, and I'm sorry, it's my fault for not timing it properly. I have an ethical framework to show you, and then usually we just redo the exercise one last time with the new ethical framework in mind. It'll take 20 minutes from here to the end, but it's already 9 o'clock, so I'm not going to force anybody to stay. And if people want to stop there, we can stop there. What do people want to do? Stay. Everyone wants. You sure?
Yes.
Okay. Cool. Okay. I'm sorry. This happened last time, so I have to. It's my fault. Anyway, sorry. Okay. So we talked. We had a discussion, so that happened. It's good. We developed an ethical framework at Aifred Health to help us deal with understanding these problems. So it's not a normative framework. So it means we're not saying here's what's ethical, here's what's not ethical. We're saying here's a framework that you can use to think through ethical questions, and then it transfers a data science ethics issue into just a general ethics issue. And the disclosure is that we do use a utilitarian framework. The way we think about it is utilitarian. So we're not thinking about specific norms that we have to adhere to. We're thinking about costs and benefits and weighing them out. And then once you have that, you can evaluate them in light of your prior beliefs and your norms. But the way the reasoning process works is around sort of understanding costs and benefits of different interventions. So there is that bias in there because I happen to be a utilitarian. So it's there. We also published this recently. So this is now been published in, it's a journal for the proceedings of a conference, the IEA conference. That was in Quebec recently. But you can find it. It's called Meticulous Transparency, and you can find it online. Or look on our Twitter page. Okay, so blah, 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 blah. I said this already. So in your push to AI ethics, technology is moving too fast for regulatory frameworks to catch up. And the current approaches focus on trying to shoehorn technologies into existing rules, which often results in a mismatch. Oops, whoa. What happened? Okay, good. So we propose an approach focused on consequences and intentions, called Meticulous Transparency. It's not only about algorithmic transparency, it's about transparency in the intentions of the developer. And it's very similar to a research ethics board application in medicine, which is something we're, sorry. Okay, so how does a meticulous transparency assessment work? You have to assess the intentionality or the purpose. So why are you developing this application? And I mean that very specifically. What are you trying to achieve? For example, one of the most dangerous applications of machine learning that I can think of is not weapons, it's targeted advertising. I think targeted advertising is terrifying, and I think it's going to kill way more people than AI-powered machine guns ever will. Because you can do things like target alcohol to people who are most likely to buy it, who are alcoholics, by the way. They buy 50% of the world's alcohol. And that leads to all sorts of problems. Okay? In fact, I met a guy who knew a guy who worked for a gambling company who said they had developed an algorithm that can tell them who's suicidal, who's a gambling addict, who has depression. And they actually said, we're using this to cut people off so they don't continue gambling. And I was thinking, but shit, if you can develop this algorithm, any other gambling company can just take advantage of that and do it the opposite way and target those people because they're the ones who are most likely to become gamblers. So again, we have this power now. We have to take it seriously. So next, scope of use. Who is this for? And does your data support applications to that population? And where is it for? Because the ethics of cameras inside a store that monitor where you walk and then recommend things you should buy are different from the ethics of cameras outside a store that watch you go by and make inferences about what it should send to your phone so the next time you walk by the store, you actually go in the store. Because you've consented to a degree when you've walked in the store. You have not consented to anything when you're walking by the store, right? And obviously for GDPR, even the inside the store doesn't count anymore. But like in North America, for example, theoretically, if they put a sign on the door saying, if you walk in the store, we're going to use algorithms to tell you things, that would be called implied consent, right? Or even semi-formal consent. But it's different depending on where the cameras are. So where are you using this? Data sources and bias control, which we talked a lot about, so I'll go quickly. Human interpretability, which we've also talked about. projected risks and benefits. You're not magicians. You obviously can't think of everything, but you have to make a concerted effort to try, so that you're not completely blindsided by something that another data scientist would have seen as being obvious, which is, by the way, how we try doctors in court. If a doctor makes a mistake, we don't say, if the best doctor who ever lived had been here, would they have made the same mistake? We say, would another doctor, a reasonable physician like yourself, have made the same mistake? If the answer is yes, they could have made the mistake, then you're clear. If no, clearly you're under average, then you're screwed and you go to jail. Or you usually don't go to jail. You just get your license revoked for 3 months and you pay a little bit of money, and then you go to Cuba in the meantime because the system is broken. But that's another story entirely. So, monitoring and contingency plans for adverse events. If you're putting this on the market, it's like a drug producer. You can't just put it out there and then get bought out and then run away to, Cuba or whatever, and say, I'm good, it's out there, it's not my problem anymore, I got my money. No, you're responsible for it. You put it out there. You have a moral responsibility to ensure there's a continuous monitoring system in place, just like there is for drugs, so that if something bad happens, you can catch it, and hopefully catch it before it gets too far. Especially if you're talking about an app that updates itself, as most SaaS things do. So, I've talked about this, so we're going to go quickly because I don't want to spend all the time here. The reason it's called Meticulous Transparency is because it's thorough. It's about being very thorough in the way you think through the potential complications of an app. And the thoroughness and how thorough you need to be depends on two metrics, two variables: the impact and the level of autonomy of the system. So how much is it potentially going to hurt or help, and how much does it operate outside of human control? So this is the metric we have. So obviously, self-driving cars and lethal weapons that are AI-powered have both high impact and high autonomy. Our solution has, we hope, high impact, but very little autonomy because it requires a doctor for it to actually do anything. Facebook picture stuff has no importance whatsoever, so whatever, low impact, low autonomy. And this is the best thing I could think of for something that has potentially high autonomy, but hopefully little impact, which is an animatronic Donald Trump. Hopefully we'll have less impact than the actual Donald Trump, though. One can never tell. So, with this in mind, well, actually, before we go on to the reassessment, I'll just give you a chance to ask any questions you have about the different assessment domains, and then we will redo the suicide prediction question with these domains in mind and see if it helps you structure your thought process any differently. So,
I have
yes.
a question about the adverse events side, because this is
Yes.
a discussion that I had about a year ago internally in a company.
Sure.
Have you seen any moves by authorities to actually push for something like this to be in place for new technologies?
There's a lot of talk, but not yet a lot of legislation. The GDPR and European law at least requires clinical trials for medically related stuff,
Yeah.
but I don't think it does the same level of importance for things that are medically related. So I've never seen anybody try and do this for advertising, and no one seems to take that seriously. So yeah, I don't think so yet, but we argue in the paper that it's important that they start doing so. Yeah. Other questions about these? No, okay. So you have same groups. You have, I'll give you guys another 7 minutes, and you guys can think through this again based on these six domains. Okay, shall we circle back and then let you guys leave? Okay, we'll go from the back up this time. So in the back. I'm very happy it's causing conversation. We have to finish because you guys have to go home. So.
Okay, so I think the major point of discussion that we had was that what kind of effect would it have when our app results in some bad event that goes public, and then overall the public opinion can go against your and can really shut down your whole thing. And that's where a clinician should be involved, because then he would be responsible and there would be less burden on the application if
with them.
To a degree. We know how to sue too, but yeah. So yes, okay, good point. Other ideas? Anybody have any ideas specifically related to the principles here? Go ahead.
Okay, sorry, is it okay?
No, that's fine. Yeah. Well, if you guys want to go for another one, we'll come back to you guys. Because I just want to get you extra space, so yeah.
Well, we were kind of like switching back and forth between if the patient or like the family is the user and when the clinician is the user. But we were definitely thinking about if the patient is going to be the user, about the interpretability of the results. That we were kind of thinking maybe it's a bit unrealistic for the average user to sort of take the result with a grain of salt, so to say, to realize that it only has the data that you gave it, and that it's not definite and for sure, and they still have an element of choice. That's also a potential danger.
It's interesting what happens to somebody who's sort of contemplating suicide, who puts the information to the app, and then it tells them you are 95% likely to try and commit suicide.
Confirmation
If
bias.
you're, yeah, exactly. If you're a fatalistic kind of person, yeah, it's interesting. Other thoughts from that group? Go ahead.
Right, we thought of two things. So, so for people who actually end their lives, sometimes they want to escape from the pain. And is it really legal? It's like, I don't know, it's a real pain for them. So sometimes if they say, 1 more year is another year of pain. So are we really, should other people really stop them from doing it? Unless, of course, they are putting other people with them, like with the pilot. And the other thing is, if we allow this and we accept this, predicting people from self-murder, self-murder, how far are we from making an app that predicts other people to murder other people? And
Minority Report.
Exactly.
No, it's a great point.
And then you take in people to the precinct before they actually commit the crime.
Very, very interesting point. And I think that's kind of what I was getting at in terms of trying to take an AI ethics problem and just turn it into an ethics problem. So what you said is very cogent. The question is it right to prevent self-murder? So far, society has said yes, because I have the power to put somebody in the hospital for 3 days without a judge's permission if I think they're at imminent risk. But the interesting question is that right? We know it doesn't actually reduce the risk of suicide in the long run. We don't know if it reduces the risk of suicide in the short run because, again, you can't do a prospective study of that.
And we don't know if we're improving the quality of life if we prolong their life. Maybe it's still 1 year of pain.
And that's the thing, it's very difficult because this is intra-individual data, and it's actually quite complicated because for the people who die, the control group is death. So you can't really compare death versus non-death for quality of life, right? So it's actually quite interesting because this is one of those sort of things we cannot actually settle as a question. So it becomes a really interesting ethical question. There's lots of other collateral information that we can use to make points. But you're basically saying at the heart of this AI ethics question is a basic ethics question. Oh, you and then we'll go to this group. Yeah, go ahead.
But I guess then you're actually kind of reaching some sort of a dilemma, because as a doctor, I mean, as a doctor, you have to decide between a myriad of different drugs and then also a myriad of different treatments, and then since the population size has increased, even though the overall health quality of the people have increased, that your workload is actually still bigger, that you still have a lot of number of patients than the doctors from the previous generation. And actually that would actually create the pressure of both actually coming to the right decision and also at the short time, and then that would actually already generate a sort of a preference towards actually making some overgeneralizations in your decisions, and then that would actually already make the general direction of the medicine towards a really, really conservative point of view, right?
Yep, absolutely, because having habits speeds things up. Absolutely. Very good point.
Yeah, and then actually based on this point of view, then every life is secret. Therefore, you have to prevent this suicide.
And that's the thing. That's one interpretation. Other people see the opposite side of things. I happen to be on the prevention side, but lots of people would say, like you're saying, who are we to determine what people should have to live through or don't have to live through?
I think if you look at ethics, it's kind of hard because there are so different baselines. Because if you look at society overall, for somebody who was, for example, performing sports before and then had an injury and cannot walk or do anything anymore, I think in society it's kind of more understandable if they want to commit suicide, whether if you have a normal person in where you don't know the mental state of, but to the outside it functions like a normal person. It's much more like we should prevent it because we see them as normal persons. Whereas if you due to illness or diseases or whatever are limited, for society it's much more understandable if you don't prevent it.
Interesting. And what's interesting actually, there's some good research that shows that people who are in that situation, if you wait 6 months, a lot of people actually adapt and they change their mind. So it raises lots of interesting moral questions about allowing euthanasia in those cases. But that's a little bit outside the scope of this, so we won't go there. This group. Come on, somebody.
Regarding the methodology, I want to say, for this situation, it didn't help me that much.
Good.
Because basically, because the problem wasn't that well defined. I mean, I don't know what such an app really. I don't know the purpose really. I can't really say, is this useful or not, and what's the question? Who is actually the LRC? Clinician. For me, it's only the clinician, and so this was I think this can be a nice framework to think about, but like all the other ethics questions, it doesn't solve that much for me.
Yeah, no, and it's not meant to solve ethics questions. It's meant to frame ethics questions.
Yeah.
And you actually have done exactly what it intends. If you can't figure out the purpose, you shouldn't be going down the rest of the list. That's why it's first.
Yeah.
So you've actually used it perfectly. You haven't figured out the purpose, so the question is, why build the damn thing if you don't know what it's supposed to do? Very, very good point. So you've actually proven the point. Yes, go ahead.
This is exactly what we're doing because we went a step back. We wanted to go for therapy and suggestions and whatever. And then we said, okay, all we can do is actually a warning system because this is going far too far. Not suicide even. It's really about, is this person therapy resistant? Yes, no. Because everything else is going basically beyond where we dare to say we want to go there. I think what you're doing is fantastic. So I think going a step ahead and predicting that's maybe a kind of side effect that we guess if our data is good enough, but this is why it's so hard. A suicide predictor is,
And yet it is
I would
being,
not dare to go there, to be honest.
and it is being deployed right now. The Canadian government has a contract with a company, not ours, curses. Mind you, we weren't in existence when they got the contract. We had just been starting out, so we couldn't even bid. But there was a company that got a contract to do this kind of thing using social media, but not for individual people, for populations. So to predict suicide rates in the population over time in order to redeploy resources as needed.
So I'm small and redhead, so there's more likely I'm committing suicide than...
No, so it basically to say in given areas of the province, do we expect the overall rate of suicide in this area to go up or down?
So they have healthcare there.
So they can redeploy healthcare resources.
Fine.
I don't know how well that's going to work, and I don't know what happens when they find out that they can make individual level predictions and they have that issue. So we'll see. It's curious because if you have the data and the algorithm can do it, and you could do it, and one engineer gets curious one night, and doesn't, and then it exists. But anyways, that's another point. Any other points before? Yes, go
Do you
ahead.
know the diesel problem? Yeah.
The diesel problem?
Yeah.
No, what's the diesel
Yeah,
problem?
this is one engineer went and made and tried out overnight. And, yeah.
What's the diesel problem?
That BMW and everybody has at the moment.
It's about
Fake.
showing you are less bad for the environment, your car is less bad for the environment than it actually is. And basically there was one engineer who was like, oh, we could do that to trick them into like lowering it, even though it doesn't lower it in real life.
This Dieselgate scandal that
Yeah.
happened with Volkswagen and then it spread for the automotives. It was quite famous.
Okay, I don't drive, so I mean, I have a license, I don't often drive, and I live in London this year, so driving is suicide anyway, so. Yes, a great point. I did not know about the diesel scandal. Now I know Dieselgate, it's great, I've learned something today. Any last points before we get, yeah, you moved.
I just want to say, I think the framework's really, really good. I like this because it does help you think about what you need to do when you develop an app. And when you start to use new technologies in this way in clinical environments, I actually think this is really useful to frame this problem. And I think the other thing that is really interesting here was the points that came up is this fails at the first step here. So that tells you, as you said, that this framework makes you think in the right way about whether you should even be pursuing this or not.
You shouldn't be getting here if you're not absolutely rock solid on this.
Just because you can doesn't mean you should.
Exactly the point. Now, I think there's actually a good case for this if it's used properly, and we're actually trying to develop one. But that being said, you know, we only do it because we have a specific intentionality in all these things. Yes, last one.
We talked about data sources.
Okay, good. Yes, that's one that we haven't talked about all that much. Let's go.
Should the patient give the correct information or not? Should we trust it? Should it be voluntarily? And how can we assure?
Or should it be passive sensing?
Yeah.
And then we trick you into giving us your data. And then, aha, you're suicidal, lock them up!
And how can we get the permission to collect the data? For example, if I go buy rope and a chair, will I commit suicide? Or if I go to the 13th floor every day and look downstairs, like for 30 minutes, maybe for an hour, maybe longer, do I commit suicide after it?
Altimeter plus location sensor. It is? No, but that's what it is. That's what it is. I ask my patients when I'm trying to find out if they want to kill themselves, well, have you walked by any bridges lately? Have you looked at the bridge? Have you, gone over and looked over the side of the bridge? And depending on how close to the bridge they've gotten and how familiar they are with the bridge, I'm more and more concerned about their bridge jumping off risk, right? So I literally do that by question. So what happens if we do that by app? Maybe it's incredibly helpful and we save lives, and maybe people who just happen to like bridges get thrown in jail. I don't know. Okay, fine. We'll do one more and that's it. Go, because you haven't spoken yet.
Maybe an interesting detail on the Gold Gate Bridge. It gives many suicides.
Yes.
And they have
the net.
A camera system on the normal people to analyze how when something jump, what they have make. And normal it is this. They know run normal. They look after 5 meters. It is deep enough to jump. When they find on the outside a picture that the AI say, okay, maybe this is the people, then they send them a normal police and the nearly that they have maybe a chance. And they have three people to catch them before they jump.
Really
maybe they jump not. This is a little bit different when you are not there, but the system.
N of 3 is quite interesting. So what is an N of 3? What is it?
Maybe it's a good system to understand people when you have like this of app. And the Americans have not so big problems with data analyze.
Yes, that's true. Well, yeah, they have big problems, but they're caused by UK companies apparently. Okay, so I will never forgive them. And I'm Canadian. Anyways, I think we'll end it there. You guys have been wonderful. Thank you so much, and I hope you enjoyed it.
Thank you very much.